I'm Ranmali Nanayakkara, and on behalf of the American Institute of Sri Lankan Studies, I would like to welcome you all for another seminar of the New Book Series. This will be our first book talk for the year 2025. Before we move on to the discussion, I would like to make the usual announcements. We will be recording this and we'll be uploading it onto YouTube. And I would also like to ask to keep your mics muted unless you've been asked to raise a question. And during the Q&A session, you all can use the chat box to send in your questions or raise your hand. Without any further ado, I would like to introduce today's speaker, Dr. Darshi Thoradeniya from University of Colombo. She will be taking us through her book, Critical History of Women's Health in Modern Sri Lanka. And Professor Bambi Chapin from University of Maryland serve as today's discussant. The Q&A session will be moderated by Bambi, and if you have any comments, as I mentioned before, or any questions, feel free to enter them into the Zoom chat, and Bambi will call out to you when it is time for the Q&A discussion. Thank you once again for joining with us. And with that, I will now turn to Bambi to introduce today's speaker.
Welcome. I am Bambi Chapin. I'm from UMBC, the University of Maryland, Baltimore County, and I am really happy to be hosting this or co-hosting this talk today about this really wonderful book. I want to introduce Dr. Darshi Thoradeniya. She's a senior lecturer at the Department of History at the University of Colombo. Her BA and her MA are both from the University of Colombo, BA in History and an MA in Women's Studies, and her PhD is from the University of Warwick in 2014. She has had lots of different kinds of support, including from a Royal Historical Award to study at the Rockefeller Archives in New York and the Library of Congress in DC, following her dissertation on women's health as state strategy, Sri Lanka in the 20th century. She's the author of publications across disciplines, and I think that's one of the things that makes this book really exciting and this conversation something I'm really looking forward to. She's published in Social Affairs, East Asian Science and Technology and Society, Oral History, and the Social History of Medicine. So you can sort of see her multi-method, multidisciplinary approach that she integrates into this really wonderful book. If you haven't had a chance to read it yet, you will be, I think, delighted by the grace with which it's written. It's really compelling and a wonderful presentation of a really complex and important argument that she's making, drawing on archival work as well as interviews with policymakers and the women who are the recipients of these policies. So I don't want to talk too much. I want to turn this over to Darshi to talk about this. I will say this book has been the answer to a lot of questions I've had over the past several decades, as well as ones I didn't even know that I had. And I'm just really, really grateful for her writing this and coming to talk with us about it today. Darshi, I will turn this over to you, and after your presentation, go ahead and note your comments in the chat if you want as you go along, and we will, but we'll turn to them after about a 25-minute presentation by Darshi.
Thank you, Bambi, for that wonderful introduction, and thank you, American Institute for Lankan Studies, for giving me the opportunity to present my book, my first monograph. Right. So let me first explain the title of the book so that it explains the methodology and approach that I have taken in writing this book. So critical history writing. History is about reporting, writing what has happened in the past. How do historians engage with this endeavor? Through analysis of sources. Critical history writing is to apply a critical lens to the sources. Then what happens is historians get to see that the past can be written through multiple ways, meaning there could be multiple narratives about the past. Not that any narrative is either correct or incorrect. Thus, historians create new knowledge about the past through critically analyzing and engaging with the sources. This book analyzes the women's health success story by having a critical approach to women's health policy and practice in modern Sri Lanka, from population control to family planning and reproductive health and rights. That is, in years, it is 1953 to 1996. Instead of considering this success story through demographic or development discourses, I read women's health and population policy documents against the grain, drawing attention to issues of women's health and women's bodies that demographers, family planners, development experts, economists, and policymakers of Sri Lanka have so far refused to recognize and conveniently and consistently ignored. Women's health has been a success story in Sri Lanka since the early 1980s. This is the accepted knowledge put forward by development experts, demographers, and economists, and it has become common sense knowledge about women's health in Sri Lanka. I disturb the tranquility of this statistical knowledge and interrogate it by bringing in women's corporeal experiences of health. This book is neither a history of the Family Planning Association of Sri Lanka nor a demographic history. Instead, it has an analysis of how the state deployed women's health and bodies in post-colonial state building and nation-building projects of Sri Lanka. This study is situated at the intersection of a number of scholarly fields, including population studies, development studies, women's studies, and the history of medicine. Since the 1970s, internationally renowned demographers, development economists, and health experts have hailed Sri Lanka as a development model based on low fertility and mortality levels, increasing life expectancy, commendable women's literacy rates, and sound public health services. In heralding Sri Lanka's success story, experts pointed to the decrease in the country's population growth rate from 3% per annum in the late 1950s to 2.2% by the late 1960s. The main objective of this research is to highlight the danger that lies in women's health success story. By doing so, I unravel how politics of population control, family planning, development, nationalism, and the neoliberal market have both produced and have been produced by the Women's Health Program of modern Sri Lanka. The other objective of this book is to interrogate the paradigm shift beyond reproduction that lies at the heart of the contemporary women's health discourse. In the wake of the International Conference on Population and Development held in Cairo in 1994, which attempted to critique approaches to women's health restricted to reproduction, a new paradigm emerged, termed beyond reproduction. Beyond reproduction disturbed the orthodox view that women's health was necessarily reproductive health. Now I will turn to sources to see, further kind of elaborate my point about critical history writing. So I have utilized new lens to analyze the same sources as development experts, demographers, and economists have used. And also I have used new sources. A critical lens was deployed by placing the same sources along the economic, development, and ethnic politics of Sri Lanka. New sources, such as communications between the inventor of the birth control pill, that is Dr. Gregory Pincus, and the initiator of the birth control pill trials in Sri Lanka, that is Dr. Siva Chinnathambi. So the communication, though, that is something very new that nobody has written about these communications and have not kind of analyzed what was going on in the global pill trials. what was going on in South Asia in terms of the global trial settings. So in terms of an analysis and a framework, I have placed women's bodies within the nexus of development, population, and women's health. According to Rostow's economic growth theory, population growth was seen in late 1950s as coexisting with poverty, destitution, a traditional society, underdevelopment, and pro-communism. Thus, US policymakers sought the assistance of demographers to formulate a population control policy to develop the underdeveloped world. Frank Nottestein and Kingsley Davis, professors in the Office of Population Research at the University of Princeton, were the two most influential demographers engaged in the formulation of population control policies. Together, they developed the modern demographic transition theory in 1945. And according to many, this provided the much needed justification for development policymakers to curb population growth in the third world. Nottestein and Davis's modern demographic transition theory appeared as a social engineering project, placing all countries on a grand evolutionary scheme running from pre-transitional to transitional to post-transitional, that is modern. So Rostow's economic growth theory also placed the countries in an evolutionary scheme running through 5 stages of growth. By sharing the same set of assumptions, both theories perceived population growth as an indication of a traditional society or initial stage of the evolutionary scheme towards development. Both these theories together became a unique explanatory model to develop the backward, non-industrialized societies of the third world. According to this model, it was imperative to control and plan the traditional populations of the third world in order to develop and modernize these countries. Controlling and planning the population was new to traditional societies in the 1950s. Thus, it became imperative for the first world to intervene in the population planning of the third world in order to maintain their capitalist economies to rebuild post-World War II Europe. A budget allocation to fund population control programs in the third world became a foreign policy decision in the Western countries in order to maintain their status quo. The Rockefeller Foundation and the Ford Foundation and the Swedish International Development Corporation Agency were the pioneers in funding population programs of the third world. Furthermore, the disciplines that engaged with issues of women's health, such as health economics, medical sociology, and community medicine, focus more on social issues in small communities rather than questioning the public health system, the welfare state, and the neoliberal market forces that have a profound impact on health as a basic right of women in Sri Lanka. So when the population growth and development were taken in as the major issues in terms of achieving development, the other things such as how the public health system works and how the responsibility of the welfare state, all that kind of dialogue, discussion, and the discourse kind of sidelined because the population growth became the common sense knowledge kind of thing towards development. Sorry, a second. So women's bodies and women's experiences and women's maties about their bodies have not come up as categories and have rarely been problematized in medical and health research in Sri Lanka. The myopic nature of medical and health scholarship in Sri Lanka is not helpful in addressing my question about the women's health success story. In the demographic and development approach, women's health is treated as numbers in state statistics, reflecting the country's performance within the linear prescribed progress towards development. Modernity, development in common sense terms in the 1950s, and questioning their fundamental truth appeared totally irresponsible and irrelevant. However, my approach to writing a critical history of women's health goes beyond statistics. It is the sum total of the discourses on women's bodies, women's corporeal experiences, and their feelings towards motherhood and having a family. By calculating fertility rates, demographers are interested in a woman's body for the impact it could have on setting the fertility trends in a country. Development experts perceive the woman's body as a reproductive machine, reproducing a future labor force. By using the term labor to denote workers as well as the pain that a woman goes through when giving birth to a child, Emily Martin argues that medical term joined forces with capitalism to create a hegemonic understanding of women's bodies as machines that will produce the future labor force. Foucault's concept of biopower succinctly places all the aforementioned ideas neatly into a package within a liberal, democratic, capitalist society. Foucault coined the term biopower to denote, here I quote, a new form of power that emerged in the 18th and 19th centuries, along with liberalism, democracy, and capitalism, through which the state both regularizes populations and disciplines individual bodies. Foucault argues that biopower comes into being as the state begins using new technologies and discourses of health, birth, mortality, and demography as mechanisms of regulatory power to exercise control over populations. End quote. Further, Foucault saw biopower as an indispensable element in the development of capitalism because he argued that capitalism would not have been possible without the controlled insertion of bodies, that is population, into the machinery of production, economic processes. In fact, his concept of biopower talks about a new political right of the capitalist state. I quote, the power to make, live, and let die. That is, the state's ability to regulate, control, and protect populations who are fit to work, productive labor force, by marginalizing bodies that are inferior, deviant, and threatening. End quote. So that is the framework in which I have looked at how population programs, family planning association work, public health in terms of family health bureau work, and women's bodies, the recipients of the public health services are being kind of analyzed. Right. So here are my chapters. So chapter 1, through a careful reading of works of demographers, I trace Sri Lanka making its mark on the demographic map of the world as an interesting case study in the 1950s, becoming a development model for South Asia in the 1970s, and the survival of this model status during the turbulent decade of the 1990s. Within this trajectory towards becoming a development model and a women's health success story, population and women's health emerged as interconnected categories in policy making. So women's health was necessarily state building, whereas women's bodies was necessarily nation building. So chapter 2 provides the institutional history of the family planning program of Sri Lanka from a fragmentary birth control movement from 1950s onwards to the rebranding of family planning as reproductive health after the United Nations ICPD in 1994. In so doing, this chapter shows how the cult of population control became the official ideology on women's health by the 1980s. Chapter 3 uses the history of the pill trials in Sri Lanka to show how Sri Lanka entered into the global pill trials as a laboratory site, prompted a discussion on contraception. I also explored the moral values around women's bodies and ethnicity, which resulted in terming the pill Vanda Behet, pills of sterility, in the late 1960s. Show how women's health and bodies became the ground on which market forces, that is Mithuri, replaced ethnic forces, Vanda Peti. This is one of the advertisements that I found in a newspaper about advertisements done by Family Planning Association about, encouraging rural women to go for family planning. Chapter 4 tells the history of the turbulent decade of the 1990s, how its economic, military, and political policies sidelined issues of women's health. By pointing out different tropes of motherhood, womanhood, and the human rights violations of the 1990s, I argue that Sri Lanka was not in an appropriate mindset to introduce the paradigm shift in women's health, reproductive health and rights advocated at the ICPD in 1994. Chapter 5, I argue that the launching of the island-wide Well Woman Clinic program in 1996 and the designing of the population and reproductive health policy in 1998 as consequences of the ICPD are both problematic and ambitious ventures. Because in an environment where human rights are routinely undermined, like in the 1990s Sri Lanka, it is very unlikely to even imagine reproductive rights. Furthermore, due to the state's framing of women's bodies for social reproduction as a response to the turbulent events of the 1990s, neither women nor bureaucrats or doctors were free to imagine the new ideology of women's health beyond reproduction. I have shown that Sri Lanka was able to implement the reproductive health component of the ICPD framework, but had failed to address reproductive rights component. In conclusion, in critical history writing, success stories are considered problematic as they are built on pillars of subjugation. My interest lies in these subjugated stories because they elucidate broader insight to the larger picture and also how power relations work between various actors in society. With this aim in mind, I have approached the woman's body through her corporeal experiences and discourses on the woman's body, which were framed through nationalist discourses during the colonial period of Sri Lanka. I placed both women's health discourses and discourses on women's body within a unified analytical framework. It would help to do justice to women's health by having a holistic inquiry in future. Thank you.
Thank you. That is, so I realize I have so many questions and I'm not quite sure where to start. But I think it might be helpful to sort of dig into some of like an illustration of some of the points that you've been making that I found really compelling. And I wonder if you might talk a little bit more, maybe from a different starting point. And again, this is me as an anthropologist thinking this way. You describe who goes to these clinics that are set up. So I want to sort of start at the end of the book. Who goes and who doesn't go, because I think that really illustrates your point about what kind of women's bodies and also the sort of distinction you're making between women's health and women's bodies, which I found a little tricky to get my head around that part. So maybe if that gives you sort of something to start with. And in the meantime, if folks have their own questions or things you'd like to hear more about, please put those in the chat and we will get to those as well.
Right. Thank you, Bambi, for raising that question. So my clinics are very much well woman clinics. So I'm looking at the well woman clinic setting because of the fact that well woman clinics are looking at women's post-reproductive body kind of body, not the childbearing body. So these well woman clinics are again set up in the same setting in the MOH office, so that some women are allowed to be there and some are not by the public health system, but by the culture or the social setting that they are in. For example, if an unmarried woman goes to a well woman clinic or a divorcee goes to a well woman clinic, then it will be looked at. They will be looked at in a different way by the others in the society, because they are not, because every week they have some clinic happening in the MOH office and people are not aware what is the clinic that is going on that particular day. So it is generally, MOH office is very much about reproductive body. So not the post-reproductive body. So that is why it is the setting is important. So it's a very third world kind of a setting where you have the same, you use the same resources to have the reproductive kind of pregnancy or neonatal clinic as well as the well woman clinic. So that is why I say, like, using the same resources can be very differently looked at by the culture of that of a particularly not exactly rural settings that my clinics were Dehiwala, that is like suburbs of Colombo. So that is what the midwives and also the women were telling me about their experiences of getting the services from well woman clinics. So that is definitely a problem, because women's health, because that means women's health is definitely looked through reproduction, nothing more or nothing less. So meaning that women can't kind of get or access public health system and care if you are unmarried, and also if you are a divorcee, and also if you are, if you're a child, if you decide not to have children, kind of. It's a very, the myopic view of women's health was the issue. I hope
You also,
yeah.
No, I think that's really interesting. You did such a nice job in that particular kind of analysis of showing how the constraints. So you have the international policy that's recommending reproductive care beyond or women's health care beyond reproduction, right? So screenings and cancer screenings and diabetes and other kinds of screenings, and that it makes sense to put these in these maternal and child health clinics. That's where you have this nice piece where someone's like, well, that's where the equipment is. That's where the people who are trained to do this.
Right.
Yet then people don't access them because they're not thinking that that service is for them. It's a really nice illustration of those things kind of coming together. I'd also love for you to talk a little bit more, and you mentioned this in your slides, about this idea. I think you just said that Sri Lanka wasn't in the frame of mind to hear the rights part, right? So out of this international Congress comes this policy that Sri Lanka, among other countries, sign on to, where they're going to emphasize women's health and rights. Right. So healthcare rights, and that part gets dropped out, and you have this really nice piece where you show how the policy gets adopted and changed in really important ways, where the couple has rights, if anything. I wonder if you could say a little bit more about that for folks who might not have been able to read that part.
Yes. Thank you, Bambi. Yes. So I have looked at the policy, say population and population policy which was drafted in 1998, to show that ICPD objectives are not met in the policy. So the policy document. So then, when I interviewed, or when I asked about the decision for not inserting reproductive rights to the policy, they didn't have a clear answer, actually. So what they kind of, in a way, evaded the question, saying it is a chicken and egg situation, saying that how to, because they also didn't know how to insert it into the policy and then implement reproductive rights. But at the same time, they are not, the medical system is such that they looked at the delivery of service, medical service, as a it's a beneficial thing to the people, and we are doing a service. So then they have to be grateful to us, kind of a that is the environment that is being created here. So then it is very difficult for the woman, especially low-income women, to kind of question, okay, this is the service that I need, and how am I to get this service, kind of thing. That kind of a conversation, there is very little space for that kind of a conversation. So then the whole idea of rights, as health as a right, is kind of misleading. It is not really that rights discourse has not gone into the policy document, neither to the policy document nor to the system, public health system. So then there is a gap that both have to fill in. Say, for example, policymakers and also the service delivery arm of the public health system. So for that, it's not only the doctors, but all the, all levels of public health servants have to kind of figure out how to address that issue about rights, health as a right of the citizen. That kind of there is no space for that kind of a discussion. And I feel, and I have actually discussed in the book as well about, it is time now, at least now, after the the ethnic conflict or ethnic war, it is time for us to kind of revisit the welfare state, because we are not in Sri Lanka. It has been, welfare state has been taken for granted, and it has been manipulated and maneuvered in so many different ways, both by the policymakers, politicians, state officials, and also people. So it is very essential now to figure out what a welfare state is, and what is to be expected, and what kind of a discourse that has to be created. So that is another issue about, that I figured out by talking to different people, policymakers, the people who receive the care services, and also the people who, provided the services. All three of them have their own grievances or issues about reproductive rights. Thank you.
I have a bunch more questions, but I also see that there are some. I want to return before we end today. I want to return to this question of what it is time for now. And you sort of hint at some recommendations that you have, both about how international recommendations ought to be more attentive to local conditions and how policies might be implemented, but also sort of what's next in this area for Sri Lanka. So we'll wait and return to that. But I see Tarndi in the chat has asked about, what about those who go through reproduction and then divorce? Can they go to these clinics? And I think that question of can and do might be something, right? Are they able to, and do they in your work?
Yes, they can definitely go to these clinics. It's just that the space, kind of the uncomfortable space that is being created for them, which made them not access these clinics. That is the problem. So it is not about, not that they can't, for sure they can access these clinics, but women clinics where it addresses all the non-communicable diseases, which is very important after you reach the age of 35 in Sri Lanka. So that is very important, but at the same time, since it is being framed within that, maternal and child health clinic, it is difficult for them to access, because when they go and go there to get the services, they are being kind of looked at. Why are they here? They have had their children, so why are they here, kind of thing, the divorces.
You also speak about how people might think about the clinics as associated with a problem rather than with prevention. You sort of talk about, if people are, you have sort of excerpts from interviews where people are like, I'm healthy. You can tell that because I did not go to the clinic for 3 years, right? Like that's evidence of your health rather than a way to take care of your health.
Yeah, that is to say that because the whole idea of health, being healthy, is an indicator that you haven't visited any healthcare setting. So that makes the people believe that they're healthy. So the whole, the preventive aspect is not being, but I must say, Bambi, it must have changed by now because of the COVID pandemic, I'm sure, because it would have, the whole preventive aspect, wearing masks and all kinds of, even now in Sri Lanka, because of the air pollution that we are suffering at the moment, it is being announced. So we are kind of wearing masks when you go out. So that is there. So that must have changed by now, for sure. If I go back to the field, I will have a different view on that, I'm sure. But when I was doing my fieldwork, that is how they kind of judged their health. Kind of, I'm healthy enough. I don't have to, So the whole preventive idea, because well-woman clinic is very much about a preventive measure, not a curative measure. But then that preventive idea was not properly kind of. It was not stated enough or properly stated in establishing the things. Yeah.
So interesting to me, sort of what pieces of ideas that sort of take fire, people really catch on to, and then other ones that are just like not that interesting, and sort of how those come in and are metabolized. John, I know you have a question, and I want to turn it over to you to ask about that, because I could keep on talking about this.
Okay, thank you. I want to pick up on your final point, where you said that in the 1990s, you couldn't imagine reproductive rights because human rights were being routinely violated throughout the society. So now if we look, say, at Sri Lanka today, without saying that everything is perfect, if we look at human rights in society in general, most people would say it's better than it was in the 1990s. But my question is that while a reasonable general human rights situation might be necessary for reproductive rights to advance, I'm not sure it's automatic, because general human rights can advance in some ways, but not in others. So, say, intellectuals being able to openly talk about national identity and history, etc., is one thing, but it doesn't automatically transfer to something like reproductive rights. So, I guess I'm asking a bit about the prospects for reproductive rights, but also I think there are probably still certain types of social attitudes, particularly in the bureaucracy, that may be just as strong as they were in the 90s, or have they been eroded by some of the globalizations and young people looking on the internet and getting new ideas about sexuality? Or does the very fact that young people are getting new ideas make the bureaucracy even more reactionary? So I guess I'm just asking you a little bit about how things might have changed. I know you haven't done actual research on it since the 1990s.
Yeah, thank you for the question, John. Even though I haven't done any research per se after 1990s, and in terms of my time frame, of course, my engagement with the medical faculty and the new programs, new postgraduate certificate programs and diploma programs that are coming up, where I also get to teach and sometimes deliver just guest lectures. The sense that I get is that reproductive rights, even though it is not still inserted into the policy, the rights discourse is a discourse that is taking place among the medical doctors, but not at the undergraduate level, but postgraduate level, among the medical doctors and also public health health officials such as midwives, the nurses, and so on, and public health inspectors, and the officers in the public health system. So that kind of, I can see that happening now, and also it is kind of and also LGBTIQ is a topic that is being discussed in these courses that I just mentioned, offered by the medical faculty of Colombo University and also by the Faculty of Graduate Studies at the University of Colombo. So in a way, I see that public health officials are aware, and also the work of the UNFPA, United Nations Population Fund, is really working on these kinds of aspects about relationships and mutual, consent on sexual orientation and all that is quite, you can see it very clearly, and through social media as well as the activities promoted and organized by the UNFPA in university settings, as well as even the Family Planning Association are quite active in promoting these kinds of rights-based approach towards sexual orientation. So that kind of a discussion is coming up. So I wouldn't. So I can see that, even though I haven't kind of looked at it in a formal research manner, but I can see that happening. Yeah.
Thank you.
Other folks want to chime in?
Is there a
Yes.
question? Is it
Thank
Rania?
you.
Yes, Rania. Sorry.
Thank you so much, Dr. Darshi, your presentation and all the information. We are especially I'm so happy as a historian, Professor Roger. Thank you so much for creating this great opportunity to us in this moment. Then I also focused my attention related to the British colonial health policy, and especially specialized the plantation labor community in Sri Lanka. At that particular field, I able to identify women as a machine of the reproduction, right? However, I'm so happy, twice happy, that she also applied the same conceptual approach towards the post-colonial era, right? I'm so happy in this particular moment. And in addition, I hope to draw your attention related to the sexual and reproductive rights in Sri Lankan society. The women's rights to make decisions about their reproductive health can be restricted due to the laws, social norms, and economic pressures. What do you think about this idea?
Laws and thank you, Ramadi, for the question. But
Sure.
say the question again.
Laws,
Yeah.
social norms, and economic pressures.
So the reproductive decisions are being kind of restricted.
Yeah.
Yes.
Yeah.
I
Sure.
agree. And when you look at the plantation sector, it is very, very
Yeah.
applicable. Yes, definitely.
Sure.
And
Sure.
also the other settings that the urban poor, all those groups of women also get restricted in terms of decision making, because that is not the woman's decision sometimes about the number of children that they should have. It's not. So my concern is that it has to be a decision by both the parties. It's not only because we are looking at a family setting. So it can't be the decision of the woman or decision of the husband, but a decision by both. That kind of a decision is important, but at the same time, there are no there is very less space for women to have unmarried women to have children. So that's another area that I haven't looked at, but that is the culturally that is not possible, right? So that is another area that we have to look into.
Thank you, Darshi. Thank you.
Thank you, Ram.
Stephanie asks in the chat, and I'll ask you if you'd like to unmute and ask your question, but it's a comparative question that you do address in the book. Sort of how does the Sri Lanka case compare with health policies elsewhere in South Asia at that same period of time, and sort of where it diverges? Stephanie, did you want to add more to that? I don't mean to. I might have missed something important in your question.
No, that's completely fine. The question is just more to understand whether there is anything that's specific or unique to Sri Lankan, the experience for Sri Lankans when it comes to women's health policies, especially during that time period, because I'm honestly not very familiar with the research within that time period. And also just to add to this question, which I was just thinking about right now, I also wonder how or if should this healing practices might also come into the picture. Like
Healing practices?
Ayurvedic medicine, for example.
Right, right. Stephanie, in terms of statistics, what the demographers and development experts say is that Sri Lanka is doing very well and kind of, Asia's island. That is what is the term given to Sri Lanka to say that population growth rate is nicely under control, and mortality rates are under control, and statistically we are doing very well in terms of South Asia. But so my whole argument is to question the statistics, yeah. So and then if you look at Guna Mirdal, who has done work on in 1950s, late 1950s, to figure out how to develop these, South Asia. So he had also taken Sri Lanka as an example for Pakistan, for India, to Nepal, to kind of plan their national development along the lines of Sri Lankan, to take Sri Lanka as a case study for them to kind of to use, right? So within that statistical framework, we were doing very well during that time. Your other question about Ayurvedic, so that is, say for family planning, it is very interesting. If you look at my third chapter, Stephanie, you would be interested to read that. It is about the pill trials. So how, when India refused to become a trial site, Sri Lanka volunteered to become a trial site for the birth control pill. So that is how the global pill trial site was selected, because we volunteered, kind of Sri Lanka volunteered. So meaning then it is very interesting to see that in 1960s, India was very much engrossed with the ideas of Gandhi's ideas of family planning, and how Dhanvanti Rao was leading the Family Planning Association of India. And then what was our take on family planning here in Sri Lanka was very different. So we are kind of, we were a country kind of trying to figure, following or adhering to the same Western framework given by Rostow and the demographers. This is the way forward, kind of thing. Step by step, different stages of economic growth was our plan towards development. So then population control was a must. So that is how Sri Lanka had the trajectory that Sri Lanka took. And then when it came to 1977, the open economy, accelerated Mahavali scheme, all of that kind of, development scheme was very much geared towards developing the nation, or developing the island nation, right? So it was, so then population control became one of the main things. So I have kind of looked at how Sri Lanka volunteered to become a trial site, and then it kind of didn't do well as a site, but at the same time used the birth control pill on women, and then it was termed as Vandapeti, meaning sterility pills, and then the market after 1977, the market made it come as Mithuri, female friend, and kind of it became a over-the-counter pill. So today it is an over-the-counter pill. It is not a prescribed pill anymore. So it's really interesting, and very ironically, when the pill came out of the prescription, pharmaceutical policy, national pharmaceutical policy was done in Sri Lanka in 1971. That is one of the very first pharmaceutical policies for the world, and which states clearly that all the medicine have to be prescribed by the generic name, whereas birth control pill became just Mithuri. Yeah. So it's really interesting to see how the market forces really entered the health sector, and then actually it is women's body that they entered in finally. So that is the whole interesting thing to see.
Darshi, you tell so many complicated stories that seem that we thought we knew the simple answer to, right? So it's sort of like, oh, the statistics on women's health and fertility, you know, they're also positive, and yet you sort of complicate that underneath. And I wonder if we could tease out some of those complicated stories that you tell. And I guess, you know, going from what we were just talking about, this idea that Sri Lanka had this dramatic drop in fertility, and yet there doesn't seem to be a population policy until long after that drop happened. So I'm still sort of like, why did it happen then? Do you have a sort of answer for us?
I don't have a direct answer for that, Bambi. So because when I went to meet the policy makers, and they were in power at the time, and now at the time I was interviewing them, they were retired, and they kind of took a very relaxed mood to say, those were the things that we were supposed to do at the time. So that is why we did it. And then anyway, the policies don't matter, because implementation was the key thing after 1977. So then we were implementing things, whether the policies say it or not, and policies are for academics, and we don't care, kind of, it's for them to analyze and figure out, but we wanted to do things. Was the thing. The implementation was the key thing in post 1977. So that is the answer that I can,
I'm also, and again, this is sort of teasing out this, the way you complicate this statistical story. It seems like you're saying that the economic theory, the demography theory, population theory is supposed to be, you drop fertility rates and you increase economic development, and that it didn't track quite that way. So that on the one hand, Sri Lanka is sort of the model in that the fertility rates drop and the age of marriage is up and women's education is up, and literacy is up for women. And yet, can you say something about that?
Yes, that is again what the development experts say is the conflict. 1983 ethnic conflict started. So then the resources for development kind of rooted for another cause. So that is one of the reasons why they say that development didn't take place in Sri Lanka as it was supposed to be. And because if you look at early, say late 1970s, it was Singapore looking at us to say, okay, let's be like Sri Lanka, Colombo rather, right? So with Colombo plan having a massive plan towards development. So, but then it didn't. These are missed opportunities. That is how I see for Sri Lanka. So missed opportunities in so many levels. So then we couldn't kind of acquire that or achieve it, but had to change our route towards something else, or towards So.
Are there other folks? I have.
Could I just ask a question about abortion? I mean, I'm thinking reproductive rights there's a lot of things in that kettle.
Sure.
And Sri Lanka has about the most restrictive abortion policies possible. And there seems to be no possibility of change. I mean, nobody would even bring it up before Parliament because you'd get hooted out. And yet Sri Lanka, it's said, has one of the highest rates of off the books abortions that there are, a lot of which are unsafe. Anyway, I just would like to hear if that ever figured into any thoughts about what a reproductive rights policy would be. I mean, that does strike me as under the category of rights, at least.
Yes, absolutely, Jean. Thank you very much for the question. Yes, it is a reproductive right, but the problem is my interviews as well as my teaching to medical doctors don't see abortion as a right. They're like, family planning is doing very well. So why do you, and Postino 2 is freely available. So why are we talking about abortion? that is where they are. So they're kind of, these are all, to the morning after pill is again an over-the-counter drug now, right? So then why are we talking about abortion? Abortion can be illegal. So it is, and they don't look at it as a right at all.
Obviously,
That's
yeah.
another, yeah.
Of the over-the-counter drugs, under the heading reproductive rights, I'm assuming mefloprexol is not one of them.
It is.
It is. You mean I
Yes.
could walk into a drugstore
Yes.
and
You ask for it. Yeah, they will sell it.
Darshi, we have a few more minutes left, and I have sort of two questions I just want to float, and you can answer either or neither, and maybe other folks do too. One is, one of the things that's so wonderful about this organization, the American Institute of Sri Lankan Studies, is that it's interdisciplinary, and your work is so much that way. But you point out in the book that women's health has just not been the subject of scholarship on Sri Lanka. And that struck me. It's such an important area. I think this, attendance at this meeting and other kinds of conversations indicate that there's a great deal of interest. Do you have a thought about why that is, or how we could go forward? So that's one sort of the how we go forward piece as scholars. And then the other piece is how Sri Lanka goes forward, what you see as possibilities. I was sharing this weekend, I was reading this out loud to a young a Sri Lankan woman who is living with me, a student, and she kept asking, well, but what about now? Well, what's happening now? Is the school still teaching these things now? I'm like, I don't know, but I will ask. So that's
Yeah. So thank you very much for that question, Bambi. So because women's health is very good in terms of statistics, that is why this is not being researched, because nobody questions when things are good, right? And it is taken for granted. So that is why critical reading or a critical inquiry is needed and essential. Because if you look at the beginning of my book and the end, my letter to my daughter, you will realize what I went through, and that is why it became. I realized that there is an issue, right? So that is that until you face something in this system, in this so-called very unblemished, very structured, and very well serviced sector, you don't see anything, anything irregular. Yeah, so that is why. So that is like, I mean, the good thing is taken for granted, right? So then you don't. That is why I think they haven't, and that is one of the things, Jean, why medical professionals don't like to talk about abortion also. That is my because whenever you talk to them about it as a right, they're like, no, I mean, right has been, we are not curbing the right because it is over the counter. The drug is over the counter, you can buy it. So why do you want to stay more than 3 months and go for abortion when it is when it can be fixed in other ways? That is one of the things that they bring out. And yeah, so that is, I think that is the issue. When it is doing very well, nobody questions it. And my interviews, I remember I was trying to figure out early family planning methods because of the incentives, right? Whether it has any eugenic effect, there is an underlying eugenic effect in it. Using the word made them kind of jump. What are you saying? The medical, and they're not just medical professionals, they are medical academics who are teaching, teaching in the faculty. They're like, no, we don't, I mean, that is not family planning. We are very focused towards family planning, and they don't look at plantation sector and how they behave or how they implement the programs there and how they implement it in Colombo 7. Those are like very different settings, and they don't look at, and also if you would have come across my argument about Mahinda Rajapaksa regime giving 1 lakh for the 3rd child of a armed forces person from the armed forces, right? So these are like eugenics in other ways, right? But then people don't see it that way. Yeah. Hi, Maithili.
So I want to call attention to Maitri's question in the
Yeah.
chat, and also to recognize that we're at time. And so I do want to thank everyone for coming. And I don't know if Ranmali, you wanted to say anything else before we wrap up, and then of course people could stay and continue to ask questions if they like.
I do have an announcement to make, but I mean, I can do it after if Darshi would prefer answering the question now, or
Yeah, let me.
then
Oh,
we can.
Ranmali. Yeah, so Maitri, you want to ask the question? Please, if you don't mind.
I have to stay off camera. I'm sorry about that.
Ah,
It's a
that's
little-
okay. That's all right. Yeah.
No, I think it's fascinating, and it kind of speaks to John's comment about rights and how local communities are kind of responding to, measuring success, the monitoring and evaluation that goes into rights-based programming. And I was curious if you came across that ICPD era, how medical practitioners and hospitals, but also, maybe particularly local organizations that are doing the kind of in between medical, educational trainings and so forth, how they were responding to kind of create those success stories. And I was so appreciative that you're kind of being critical of these success stories, but the actual labor that was going in to demonstrate success as couched within these maternal and child facilities and so forth. It's really fascinating because they would say, oh, it's medically necessary, for instance, to have this, termination of pregnancy, or it's, when it could have actually been an elective termination and so forth, right? So I was curious if you came across those statistical kind of conundrums and so forth. But.
No, not exactly statistical, Maitri, but I remember Family Planning Association, the medical director at the time was like when I interviewed her, it was Shriyani Basnaika, she clearly said that despite the, the human rights violations and the war that was going on, Family Planning Association was allowed to go to travel the entire country, and they were very supportive. They were never stopped. Family Planning Association vehicles were never stopped at any, say, checkpoints. They were checked, but they were not they allowed the Family Planning Association work to take place. So they, in a way, family planning was looked at as a very positive thing by both the government as well as the other parties that were not very, the warring parties of the government, the JVP and LTTE both. So in that way, they were recognized. And then, but Family Planning Association continuously told me, like all both the two doctors whom I kind of spoken to, that they're not doing anything on abortion. So even though a woman comes to them asking to abort the child, but they're not because it is illegal and they can't do it. That is their stance on it, but the services were rendered very effectively and very clearly, and they didn't face any antagonistic kind of situations during this the war situation in the country.
No, it's really interesting. I was thinking, Jean, also of your work and how hospitals are classifying, right, certain acts or like medical transactions. So it's and thinking of the global context. So thank you so much. So
Thank you for raising that question.
Darshi, do Sri Lankans, some Sri Lankans use the term womb wash, and they don't think of that as an abortion, but others of us would with that as an early abortion. And sometimes I know the Family Planning Association off and on has been allowed to do womb washes, and then all of a sudden they're not allowed anymore. Do you have any sense of who is it who's allowing them or not allowing them? And what
I
change?
don't, but I have, Jean, I have heard the word womb wash, but not, I haven't discussed anything about womb wash with the medical director
Yeah.
of the Family Planning Association or the interviews that I have had.
Yeah.
So,
The
not
other
sure.
term is menstrual
Thank you.
regulation,
Menstrual
which is-
regulation. Yeah.
you know, an official part of the family planning policy in Pakistan. Of course, it's not about menstrual regulation at all. It's about an early abortion.
Yeah.
And I don't know if there's any, that's a sort of legal term or term that's used in Sri Lanka.
Yeah, menstrual regulation, I have seen that in early 1940s advertisements, in which, yes, published in newspapers to regulate menstruation at even though you haven't had it for months. That is what they say in the advertisement. Devi and Specs are the two pills. Devi pills and Specs pills, imported from Madras. So that is what I have seen in advertisements, but I haven't come across the word menstrual regulation in my interviews. No.
Interesting. Thank you.
I want to wrap up the sort of official public part of the talk. I do think if Darshi, if you're willing to stay on and if people have more questions, this is just what a wonderful opportunity to get to talk about this amazing research. And thank you for sharing it with us. And I would point everyone to see that the link had a link to the book. So if you haven't had a chance to see that yet, I really recommend it.
All right. So yeah, it's a very interesting and a timely topic to discuss on, and I'm sure y'all have other questions to ask as well, but we'll formally conclude the session and then y'all can stay back and then have a discussion. So thank you everyone for joining today. Special thanks to Darshi and Bambi for sharing their thoughts with us on the book Critical History of Women's Health in Modern Sri Lanka. I want to make an announcement before we wind up the session. New AILS History Seminar will take place every Tuesday from March 18th till April 8th. So y'all can register for that once we open registrations, hopefully in few weeks' time. So with that being said, we end today's discussion. Thank you everyone and have a great week.